A warm welcome to Nicholas Waters, CEO of IRLAB Therapeutics, Viktor Siewertz, CFO of IRLAB Therapeutics, Charlotte Stjärngren, partner at Cord Communication, and Fredrik Thor, equity analyst at Redeye.
Thank you, John. Maybe just as a starter, could you maybe just in 30 seconds, Nicholas, explain what you do?
IRLAB is a biotech company listed on Nasdaq in Stockholm. Developing drugs for Parkinson's disease.
Good and short answer. So maybe my first question was, you target Parkinson's disease. It's a tricky disease, and we still don't maybe fully understand what causes it and the underlying process. With this in mind, can you maybe explain your business strategy? How do you target these subcategories of Parkinson's disease?
IRLAB has had a very focused strategy on Parkinson's disease. That is correct. And what we've done over the years is that we've looked at the progression of the disorder in the patient population. We looked at different needs at the different stages of disease and targeted certain projects for each of those stages. That has been our strategy in PD. Concerning PD, there are of course knowledge about the reasons for why Parkinson's disease occurs. 5% of the can be explained by genetics. And then there are environmental factors, toxins in the environment, etc. But for the most part, it is really unknown why it occurs. But what happens in the brain is well known. And that is, thankful to that, we can actually develop new drugs for the disease.
And your lead candidates, mesdopetam and pirepemat, what type of, what do they address?
They address complications in mid and late stage Parkinson's disease. If we look at mesdopetam as the first case, it's a drug which we introduced together with the gold standard treatment today, levodopa, and it prevents dyskinesias and psychosis, which is two different symptoms which complicate lives quite dramatically for these patients over the course of the disease. Pirepemat is a drug in a totally new class of CNS molecules which treats or improves balance. There is a loss of balance function in these patients in the late stages, and we can counteract that with pirepemat, and we are currently in a phase 2b study with pirepemat as well as mesdopetam.
And how do you combine your therapies with today's standard of care? Will it be combined with, and how will it work with, for example, if there were to be disease-modifying treatments in the future? How do your drug candidates kind of interact with the current standard of care and also potential new ways?
Current standard of care is based on levodopa, which was discovered in the 50s and early 60s, has been used since then. It's a fantastic treatment in the early stages of Parkinson's disease. However, there are complications along the road. So together with levodopa, our drugs will function very well. We've studied that carefully before we went into phase 2, of course. And then concerning disease modification, which is a complex word, there are so many definitions around this buzzword. But in principle, if we're looking at what has been tried so far in the Parkinson space, is to slow down disease progression. But you cannot really return to normal function. You have lost neurons in the brain. You can't resurrect them. There has been tests or studies doing that as well in history. Has not succeeded yet. So at best, you can probably slow down the progression of disease should one be successful with any of the strategies that are out there today. So far, there has been no data really supporting the strategy. But should they occur, we foresee there will be no change in the need for instance, levodopa or our drugs. Victor, any comments?
Yeah, and also, I mean, if the disease-modifying drugs will make more people or more patients with the need for symptomatic treatments. So you could say that if there are drug disease-modifying drugs that are that can be used, the need for our drugs will increase.
And I believe in your Capital Markets Day, you also mentioned the possibility to prolong the onset of LIDs and not only reduce the symptoms.
Yeah, with mesdopetam, we have preclinical data supporting that pre-treatment with mesdopetam can actually prevent the occurrence of dyskinesias. So that's an expansion possibility within this program, which could be really helpful for the patients.
Interesting. And Piripamaten, which addresses falls or imbalance, can maybe expand a bit on that, the need or the unmet medical need, because you know it best.
Falls in Parkinson's disease is the biggest unmet need so far. Patients lose their balance over the course of the disease. That leads to falls, which leads to fall injuries, and fall injuries are extremely costly for the individual and for society. There are no treatments today. So what we did was we specifically designed a program to look at the reasons for falling. We discovered certain pathways in the brain which are involved in the control of balance. Or we utilized the knowledge about those pathways, I should say, by targeting those with Piripamaten. We did some preclinical work and went into the clinic, performed a phase 2A study a few years back, and could show that we improve cognitive function, but also improve balance. Looking at the academic setting, there has been a number of trials addressing falls. So from a design perspective or a study design perspective, there are lots of knowledge to build on, and that's what we've done with our study, our ongoing Piripamaten study. However, there are many ways to measure falls per se. How do you measure a fall? How do you assess a fall? And we've had a long discussion with the regulators on how to do that, and we have been implementing a good method now, a traditional method with diaries actually in our current study. Just to conclude, clinical benefit here. A 25% reduction in fall or fall incidences is deemed 25% is deemed clinically meaningful. And there are no treatments, as I said. Canes, supportive systems, physiotherapy is what are offered today, but with no long-term effect.
And as Nicholas said, there are huge costs associated with the falls for the society. So just decreasing the number of falls will have a big impact on the societal cost. And also when we do the health economic analysis that we've done regarding Piripamaten, an important factor in that is the quality, the quality of life assessments that's been done. And that increases a lot as well, because if you are prone to fall a lot, you will have a fear of falling, which makes you more basically you want to sit down, you don't want to go up and do things because you're afraid of falling. So if we can take out the risk of falls, then the quality of life will increase a lot for these patients as well, and that impacts the price that we will be able to get for this. So in our health economic analysis, it seems like we could argue for quite high price point in this indication.
So I understand how it's going to be hard with the falls, but you're in a hard area.
Yes.
being in Parkinson's. So could you just briefly outline your next steps, the important milestones for us to look out for?
If we look at our whole pipeline, the next or one important milestone now is the conclusion of the phase 2B study with mesdopetam, a study which we are running under the umbrella of IRLAB, but in collaboration with Ipsen, our partner. We licensed the program to Ipsen last year. So the conclusion of those data, the phase 2B study, is of course a very important milestone. Next in line is of course next year in the fall we expect to have data from the Piripamaten study, end of 23 basically as well, from the phase 2B study that's ongoing right now. But also if one looks at our pipeline, there are a number of preclinical programs now which we are pushing towards phase 1. So initiation and completion of phase 1 studies during the coming 2 years, in our full pipeline. So we have a quite substantial news flow coming during the next 2 years in IRLAB.
Interesting. And if we think about the very long run instead, in the upcoming maybe decade or so, what can drive growth beyond these known clinical candidates? I presume that you want to talk about your platform a bit.
Absolutely. The platform that we have is quite different from what you normally see in the industry. We have a machine learning based and AI implemented strategy to discover new molecules. It's highly efficient, and that can be shown easily by looking at the pipeline that we've generated over the past few years. So it's highly productive. We also see that we have a higher likelihood of phase transitions once we have chosen a CD, which makes the calculations or the modeling quite interesting for us. So we have had a very strong focus on Parkinson's disease in the past few years. We've mapped out that, as I said. Of course, we have similar maps on other types of neurodegenerative, neurological, and psychiatric disorders. And looking in the very far distant future, I'm sure that what we will focus on is to some extent broadening our portfolio into other neuro disorders or psychiatric disorders. Actually, there are big unmet needs in depression and in schizophrenia, for instance, still. So that's further along the line. And perhaps even further, the technology that we have is applicable on other disease areas as well. So we can go outside of the brain in the future. But that means we need to start building a database now.
And from a financial perspective, I mean, right now the business model is to find partners after a proof of concept, whatever that is. So that is a strategy that we will continue. However, looking into the future, when we have the milestones coming in and eventually the royalties as well, then hopefully we will be able to transform the company to actually take the compounds to the market ourselves.
Perfect. And maybe as a final point here about mesdopetam, which is a big big milestone for the company. It will for investors as well.
Yes.
What can we expect in terms of clinical effect and from a statistical point of view? Like what should our expectations be before that?
First of all, clinically relevant improvement in the measures that we use is around 1 hour improvement in what's called good on, that is good motor function 1 hour longer. That's clinically meaningful or relevant according to all the data out there and experts. We had experts actually visiting our Capital Markets Day recently, which you can see on our website where that is clearly stated. So that's 1 hour. Going back to our phase 2A study with mesdopetam, we saw we could actually achieve quite a lot more. And the ongoing study is designed to be able to actually catch that better effect. So of course that's what we're looking for. 2 to 3 hours improvement in good on would be fantastic. But not only that, the thing here is that if you improve good on, it always costs something, at least with current treatments. What we've seen in our previous studies and what we hope to be able to show now in the phase 2B study is that we get this improvement without any cost in terms of additional side effects. And side effects of today's current treatments are psychosis and edemas and problems like that, which we don't see in our data. So the cost-benefit balance actually increases both in terms of increased improvement in good on, but also in the loss of or reduced side effect profile. So the balance there is something one has to, of course, discuss with regulators at the end of the day. But from a drug development perspective, that is a sweet spot to be in.
Perfect. That's all the time we had. So thank you both for being here.
Thank you very much. Thank you very much for having us.
Thank you all for an interesting conversation. We will now take a short break.